Let us, and we're there. Okay. So I'll pick up where we left off, everybody. And it surprising, I mean, just a side note, we're pretty far along. Now we have a quorum. Thank you. Because you're here and I'm happy. It's okay. Everybody else, if you're back row bandits, you don't need, oh, it's not, you don't have to be sorry. It's all good. All right, let's see. There are, oh, that was the announcement. There's not a lot left for us to cover scholastically after this. We just do male and female reproductive. So, and there, right now, it's a little hard for me to do some of the stuff because my university laptop is deceased right now. I don't. It appears to be on life support, and I've been in contact with, but they haven't gotten back to me. I went over there with my laptop; it just died. And there's a problem with the power cord because I take it home all the time, and then when I plugged it in here at school, it wouldn't plug in. So, and a lot of my stuff is on there. I mean, I can access it, but a lot of the save files and things like that. So it is somewhat problematic. But from our purposes here, it really shouldn't impact us. What I'm trying to do, my anticipation is I'm probably going to figure out one of the days. What did we talk about next week when to do this exam? I mean, when it's not going to be here. I'm going to send it to you. I don't know what else you guys have going on next week in your other class.
Genetics test Friday.
On Friday. So it'd be easier if you got a hand on this thing on Wednesday or either Monday or Wednesday. Yeah. So that's why I want. If not, I'll have to figure out a different way to do it. I mean, I certainly have the exam, but the loaner. Are you ready? Even though it's a nice system, it's a Chromebook, and so it doesn't have PowerPoint. It doesn't have that. I have another computer upstairs. I might have to turn to do that because the basic computer, the Dell I use for our business at home doesn't have that stuff either because I didn't feel we needed it. And I do a lot of work on the big iMac upstairs. I have another computer. You have an online business, you have a lot of computers. Too many. So I'll figure it out. Maybe Monday I'll get it to you, and I'll leave Scantrons or bring them, if I think about it, bring them into class on Monday or bring them into lab on Wednesday, and we'll go from there. Okay, because I wanted to get through this so we could do dissections and at least enjoy ourselves a little bit. At least do one dissection, maybe save another one for after, because obviously we don't have anything going on prior to that. Okay. Yes, sir.
So we have that that's due Monday.
No. I'll get it to you on Monday. And I would think I would give you a couple. I would give you like till Wednesday to submit it.
But test you gave us a take home.
Oh, that's due Monday. That's the lab. That's not lecture. That's lab, isn't it? That's lab. Did you everybody pick up a answer sheet? Yes. Yeah, there should be one over there. I think I left one out there. If not, I'll be in the micro lab for about 15, 20 minutes before. So if there's not one there, you can, we'll get you one. That's it for announcements. So I just wanted to let you know if there's any so me accessing or processing certain documents is potentially problematic, but it shouldn't be long-term wise. So this is where we left off. You didn't miss anything. We're just starting. That was just sort of business stuff. To summarize, on Monday, I'm going to give you an exam. That's a lecture exam to return by Wednesday. That's one sentence, and I took 5 minutes to say it. Which is why I'm overly verbose. Not to say wordy. Or prone to hyperbole. Sir? Yeah. Yeah, I emailed it to you. But did you pick up an answer sheet?
I did not.
Well, there's one, should be one in that little, it's almost like an end table sitting between mine and Dr. Lasota's office. All right? Good. So this is the last, and so really the next stage of this anatomically is to look closely, and again, this is a pulled apart, they're much more compacted, but to demonstrate why we call them convoluted tubules, the loop, thin, and descending is always thin, and ascending is always thick. This is a convoluted tubule. As you can see, multiple entries in what's called the collecting duct. That's there. And again, the series of these is what gives that sort of striped appearance, the appearance. The other thing that's noteworthy, and it's more physiological than anatomical, is that the afferent arteriole, the one going into the glomerulus, is always a little bit wider than the efferent arteriole. And we'll see it a little more up close, realistically, as compacted when we looked at really the control mechanism, which you're going to see is called the juxtaglomerular apparatus, meaning next to the glomerulus. So on with the show from there. So first we divide these into two different kinds of assemblies. Cortical, the vast majority, these do most of the processing of substances and electrolytes and chemicals. This is not so much about concentrating the urine. The other 15%, the juxtamedullary nephrons, they're all about really concentrating the urine because they have a much, much longer loop. So the cortical nephrons, when I talked before about basically in the proximal convoluted tubules, 2/3 of the work is already done. And they're very, very busy area. That's where the cellular aspect, the anatomical look of the cells, with the abundance of mitochondria and the abundance of microvilli, suggest that there's a lot of give and take, a lot of processing, a lot of pulling it in, a lot of getting it out. And again, when we get into the physiology next term, a lot of the pulling it in is for stuff to be secreted later to create concentration gradients. And then we'll see a lot of like co-transport and anti-transport, which, to me, it's almost like if you're, like a swimmer would call it drafting. You're basically using, or somebody, a bike rider, a professional bike rider, trying to get behind somebody to sort of block the wind and sort of follow them in. That to me is like co-transport or anti-transport. So cortical is just that. They're nearly entirely into that area. The noteworthy feature is the veins are draped. These tiny venules that eventually become the veins leading out of the kidney that have effectively the reprocessed blood down the road, okay, so what effectively they have done is they've reclaimed the filtrate after a lot of this sort of chemically based processing, not so much the water concentration, are draped almost exclusively over the proximal and distal convoluted tubules. And so they're called for around tubular capillaries. You can see the loops are tiny. Very, very tiny comparatively. And you can see it does have a thin and a thick section, but there's really not enough distance there. You'll see when the distance down in the physiology part of the program, as it goes farther and farther deeper into the medulla area, that's where the concentration gradients for water maneuverability are established along, and you can see there's no capillary bed or no creation of venule structures around the proximal and distal convoluted tubules. It's all draped over this long, long loop. And because it's so straight rather than all twisted and turned, they called it recta. Remember, rectus for straight, vasa, straight vessels. So famously, peritubular capillaries in the cortical nephrons and the vasa recta, even though there's proportionally less of them, are in the juxtamedullary nephrons. This is all about the water. And down the road, like I said, this is the most complicated area of processing. Every time I explain it, I understand it a little bit better, but not great. It's called the countercurrent exchanger and the countercurrent multiplier. So it sets up a continual gradient to pull water out and reclaim other materials at the same time. It's very, very interesting. Okay, so the capillary beds, glomerulus, peritubular, vasa recta. Glomerulus, we look more closely at the capillaries themselves anatomically. Again, the unique system that has arterial in and arterial out, because pressure is what's creating the movement of particles, not expenditure of energy and therefore the oxygen that's in that blood. Okay. High, the afferent arterioles are larger, as I showed you before, and they have a lot of resistance because it's designed for high blood pressure. It has to work at high blood pressure, so they're less resistant to tearing. A typical arteriole with that much pressure would give way. So these are lower pressure. These are the capillaries adapted for absorbing those substances. They come almost immediately after the efferent arterioles. They cling on to all those proximal and distal convoluted tubules and eventually become venules or empty into them. Vasa recta parallel those long loops again. Okay. They arise from the efferent arterioles once again, serving that juxtamedullary. And this is, again, all about urine concentration. It's really a big deal. The longer it stays and flows around there, the more concentrated. You know yourselves. I guess the best way to explain it is, let's say, for a pregnancy test, a home pregnancy test. So what do they tell you to do? You take it's a first morning urine specimen, and you have that, whatever the device is that you get anywhere, and they're about 99.5% accurate to determine. That's because the urine is so concentrated, less water, more stuff, it easily reads for what's called HCG, human chorionic gonadotropin, which we're going to look at again in the physiology aspects in the next units that are there. That's the idea. And a lot of tests are done like that. They want that first specimen in the morning. So this is an actual micrograph. This is the tuft of capillaries. And you can take a look yourself. Wider afferent arterioles entering, thinner efferent arterioles exiting. And you can see how clustered they are together. It's a lot. And so this is the illustration you just saw before, and you see it all the time. And yes, you'll see it again in a labeling exercise. And this is the system that probably has more to do with auto control. Because we really don't have to, as long as our kidneys are working properly, we don't really have to give them a second thought. And a lot of times they'll adjust. This is the way they adjust to fluctuations in blood pressure. If you all of a sudden decide to have, like my kids did when they were little, they'd get McDonald's French fries and get salt and just dip them in salt. Other than my daughter who dipped them in her Frosty from Wendy's. Hey, that's why she looks so nice today, I'm sure. Oh, I can't even show you the picture. Yeah, I can show you the picture.
Okay. Gotcha.
She and her daughter were out. One of their outfits. You got it? Help me. So I showed it to Dr. Hillwig and I said, this is why you should be happy you have boys. Children. Okay, now, so this involves, and it's not 100% consistent, it kind of is either around the ascending limb of the loop or around the afferent arteriole. They're close, they're sort of intimately associated. And this has a lot to do with pressure and filtration. There's two kinds of sensors. There's a pressure sensor, and there's effectively a chemical sensor for salt levels or osmotic levels, if you want to think of it that way. So you see three different cells. Now, in that ascending limb of the loop, or perhaps even a little bit closer to the distal convoluted tubule, you have these slightly taller cells that are called the macula densa. They are chemical receptors for salt. You have granular cells. These are the very famous JG or juxtaglomerular cells. These are larger smooth muscle cells in the arteriole itself, and they're mechanical receptors. And they sense blood pressure changes in the incoming arteriole. And you'll see the illustration shortly. And additionally, they can release secretory granules with this chemical renin. This is different, and I always misspell it on a test. So, and I'm not trying to trap you. That renin is something babies may have that allows them to digest certain kinds of milk, but it's only really in infants. This renin has one end. This is the critical piece because it activates an extraordinarily important mechanism called the renin-angiotensin aldosterone mechanism. That's the big player in maintaining blood pressure and fluid balance. And between the arterial and those enlarged tubule cells with a bunch of gap junctions for signaling are these extraglomerular mesangial cells. So I like mesangial because it's like sending a message. That kind of speaks to me. And this is what he looks like up close and personal. So you can see him when you look inside, and this is sort of the diagram. So here's the slightly longer, and obviously in the ascending loop, sometimes it's in a distal convoluted tubular. Those are the ones that are salt sensitive. Here are the ones that relay messages between point A and point B. Here, these are the muscular cells that also can produce the granules of renin and feed them directly into the bloodstream, I guess, by way of the arterioles. Surround the afferent or incoming arteriole. Here's the outgoing or efferent arteriole. And what it allows it basically to do, adjusting for pressure and salt concentration. Whether you need too much pressure, you want to release fluid. Okay, so how do we release fluid? We widen the opening because you have more blood flowing. The more blood, the more filtrate, the more urine. If you want to retain fluid, you do the opposite. You narrow it. Okay, you want to hold the fluid in there longer. It's a very interesting mechanism in that regard. So here, we're not going to do the physiology, but this gives you an idea. 60 times a day, think of that. 2.5 times an hour, we're running through the volume of our blood, a quarter of our oxygen. Okay, blood minus the proteins and the formed elements that are there. So it's minus the proteins and the cells would be a better way to express that. And the urine is, we reduce it by, we reclaim 99% of it. So you can do the math and you basically get around here, 1.5 liters. That's average. I mean, it's a little different about, if it's a day when you're doing a lot of activity and because you're getting rid of fluid in other ways as well. Or, when if you're, for whatever reason, drinking a lot, it doesn't have to be, not suggesting alcohol. What's interesting with alcohol, why we tend to urinate more, is alcohol inhibits one of the hormones called antidiuretic hormone, made by the hypothalamus. And so not that any of you would have noticed this, but perhaps one of you might have noticed in the back. I'm sorry. That you have to go more frequently when you're having a night with a certain degree of excess. I wouldn't know. I'm still getting over the fact that when we had this goodbye, see you in a few months lunch with my son, that my granddaughter, who'll be 22 in December, is taking out her purse and her ID and ordering a cocktail at lunch. It's like I'm going, I really can't handle this. And since my daughter did also, it's the apple didn't fall far from the proverbial tree. Did I mention not to have children if you could help it? What? I wouldn't have any stories. My other one's calling me this morning because it's one of those, at work, sometimes they open like a window so you can set your benefits, and he had one of those. Which one of these plans should I choose, Dad? It's like, I don't know. Say, you're accident prone. Get the one with the most health insurance. So this is the 3 things that occur routinely in the kidney: filtration, reabsorption, and secretion. Filtration, that's all about the glomerulus. Reabsorption, the vast majority is in the proximal convolute tubules, but there's some in the distal. The secretion is mostly in the distal, but there's also some in the proximal. So there's a little bit of both. And they show you this, and it's not really, and again, the filtration is not energy, but the other ones are. Secretion and reabsorption are there. And why does the filtration work? This is more anatomical. The endothelium, the lining, the simple squamous cells have little openings. Fancy name is fenestration. It means a window. The basement membrane kind of fuses the layer so it's relatively thin. And you have these podocytes, which are foot processes that can adjust the slits to allow for more or less filtration as needed. And you'll see they take this illustration from an actual micrograph that you will see. So again, the wider, that's the nugget here, the wider afferent, the narrower efferent. This is the Bowman's capsule. Again, simple squamous epithelium, but creates a certain amount of suction pressure. And the stem of that funnel, indeed, is the start of the proximal convoluted tubule. Again, you can see the cells with these leg-like projections. That's why we call them podocytes, foot or leg-likes that can adjust the slits. And little pores are the fenestrations. So you can either cover more of them up or leave more of them open. Just like, if you're going to open your windows wide on a day or you're going to close it, depending. Think of it, and that's the actual micrograph where the artist took the rendition from. So you can see how they would come this way. And they go, and this is physiology, and we're not going to do this. And the big thing is it's about size. Okay, those are tiny slits and tiny openings. Formed elements, white cells, red cells, platelets, proteins can't get through. They can clog up the works. That's why, even though you're sucking out most of the liquid, you still have to have enough liquid to keep the blood flowing, so to speak. So it's not like it's that all of a sudden you have no liquid in there whatsoever. You have enough to maintain the flow that's going on. But there's just a tremendous. I mean, remember when you didn't see that blood. About 55% of the blood normally is plasma. And then even when you see when we spin down a tube of blood, and we do that next term and show it to you, what it looks like, it's still liquidy where the cells are packed together. So it's enough to keep it liquid and flowing. And then this is all the pressures that have to do. And again, we're going to do that part in the physiology. One of the more difficult areas. There's certain areas that are inherently hard to understand. Kidney is one of them, I think. Sometimes heart physiology is one, I think. Endocrine physiology. I mean, those are really, in the old days, we'd call them the doctor's doctor. Basically, where the ultra smart doctors go and they certify in certain fields. And did I tell you, a guy who our kids went to school together and then both started Duquesne. I don't know what happened to his kid, and he's probably a few years older than I am. He was at West Penn, so it's part of AGH's system. And now he was up in Sewickley, and a couple of my students were tagging with him years ago. I don't know if he's still there. He's a couple years older than I, maybe retired. He was board certified in internal medicine, endocrinology, and diabetology. Smart. Did I tell you about my mom's best friend's son? I didn't. There's like the smartest guy you know. That's him. My mom was blessed until nearly the day she died with a best friend for, are you ready? 80 years. They met in 6th grade and stayed best friends from after that. Both sets of parents together. They each had 2 kids. She had 2 boys. Neither mom went to college. Girls didn't go to college then. They became secretaries. They basically took secretarial schools. The only women who went to college who got out of high school in 1936, it's a while ago, okay, were either teachers or nurses. They were the only ones who went farther along. I mean, it's the way the world was then. I'm not apologizing for it or saying, but it's just the way the world was. And I understand we're approaching a war as well. So they were both brilliant. She and my mom. My sister was surely smarter than I am. Okay. And remember I told you I was 3rd in Scrabble in the family, and my mom was 1st. She was 2nd. English teacher, MBA, all that good stuff. And she had 2 boys. The younger of whom was very extroverted, fun guy, became an oral surgeon, just great guy. The older one, to this day, the personality of this desk. Brilliant. Maybe it has to do with a lot of other factors. He went to Muhlenberg College in Allentown, PA, which is a very, very strong academic school. I went to Lehigh to start, which is one of the schools in the same area. Lehigh, Lafayette, Muhlenberg, we're all in that particular area. Allentown, Bethlehem, Easton. He graduated #1 in Muhlenberg. He went to Jefferson Medical School in Philadelphia. #1. Pathology resident, Sloan Kettering trained fellowship in pathology. Officially the smartest guy in the room. When I would have a tricky patient, I would call him up and say, what do I do? That kind of thing. I think he's still, and he's got to be 75, 76 if he's a day. I think he still may see patients. Moving on. But I always occasion to mention that about certain areas are just extraordinarily difficult to understand. So I'm not going to go into the physiology. This is the renin-angiotensin mechanism, and we should mention it because when we talk about physiology, that renin that's produced is produced when there's insufficient blood pressure. So one of the changes that happens when there's not, when the pressure sensors in that system, okay, those juxtaglomerular cells begin to make that signal. One of the things they produce, those little granules, is renin that goes directly into the bloodstream. You're going to go over it several times. We do it in blood pressure physiology. We do it here. We do it in endocrine. So effectively, what it does is it's the start of the activation of a chemical that's in your bloodstream called angiotensin. Like most enzymes in your bloodstream, most powerful tools, they are precursors. So it's called angiotensinogen. You're going to have to write it down here to see it down the road. We don't really talk about it here. That angiotensinogen is activated by renin to angiotensin 1. Then it's activated again in your lungs to angiotensin 2. That's a big player. Blood vessel, tensin increases tension. So one of the things it does is tightens blood vessels, makes it more taut. Next effect that it has, it tells your hypothalamus to make you thirsty. So you drink more fluid relative to your blood pressure. It calls for the release from the hypothalamus of antidiuretic hormone. That's the thing that alcohol opposes. And what that does is it reclaims more fluid in your blood from your urine. Raises your blood pressure. Number 4, and most powerfully, it triggers your adrenal glands in the adrenal cortex to manufacture aldosterone. And aldosterone basically in your kidneys inserts little openings that reclaim sodium, okay, from your urine. And so that's really and sodium and potassium are always going opposite directions. And so I'm fond of saying this. You'll hear me say this a bunch of times, particularly those in physiology. The reason it retains fluid is it's called Stein's Mary had a little lamb rule. Wherever sodium goes, water is sure to follow. Remember Mary, lamb. You see? Everywhere that Mary went. Nice lamb you got there. Make me an offer. And so there's a lot of different things that control. We'll get into that. And there's other things that are there. And we'll get into the effects that they have, adenosine and prostaglandin. This is the angiotensin 2, blah, 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 blah. That's it. Almost done with the kidney. Don't thank me. So there's really nothing else there in that PowerPoint. In PowerPoint 2, okay, part B, as it were, it goes through more of these different steps. I'm sure you can try to see me scrolling through it. So it's all physiology. The last little bit of anatomy is coming. and that is the ureters, bladder, etc., etc. So I mean, you see, it's very physiologically oriented. Just watching what I'm doing, this is all about osmotic gradients and the countercurrent multiplier and the exchanger. We take a fair amount of time in physiology. That's why I have a lot of time in anatomy and not much time in physiology to explain all this stuff to you guys. And so you see, if you're going to take, any of you are taking our MCAT class, we do this fairly early on. I tend to do reproductive and urinary early on because you don't get until later on in physiology. So it's the way Dr. Hilwig and I do this. So some of you are going to have me twice. I don't know how you put up with me. Even I don't want to listen to me 2 times a day. And this is all renal stuff and chronic renal. And urine, again, this to me is more physiological, but understand just briefly so. It's mostly water and solutes, and the big players are right here. Remember I said it's all about nitrogenous waste. Most of it's urea from amino acids. When we deaminate them, uric acid from purines. Okay, remember the purines for your biochemistry fans, adenine and guanine. You don't remember that? You should be. Are you going to take it?
Yeah.
See? We're giving you a leg up.
Thank you.
Yeah. I watch it when I say a leg up and my dog is there. Get out of the way.
Yeah,
These guys, leg lifters are us. Not as good as our other dog, our older dog, the one who died. God, it was like vertical. It's impressive. And creatinine, which comes from a protein, a nitrogenous protein agent that's important in muscle activity. And so I just thought I'd throw that out there for you. We won't go into it, all that stuff, etc. This is the anatomy part. Nothing physiologic happens here, only problems. Okay? The ureters are relatively slender. They look a lot like microscopically as the esophagus. They're fan folded. So that when there's urine in, they can expand, and when there's urine out, they contract. They start roughly at the level of L2, vertebrae speaking, and they are basically the stem of the funnel, which is the renal pelvis. They are retroperitoneal. They enter the back of the bladder, and indeed the urethra exits in relatively close proximity to that in a really important anatomical area. So they enter at the base through the posterior wall. And what happens when your bladder fills, the reason you don't get urine backflow is those ureters close. That's something that they check for when you're analyzing somebody's urinary tract problems. Doing a thing called a cystoscopy, you want to check, to make sure that they're working the way they're supposed to. Look, this is where my bladder cancer is, so be aware that you'll have a couple of questions on it. They're made of, and you may remember it from early in the course, transitional epithelia. Transitional are stratified epithelia. The difference between, remember when we have stratified, we look at the outermost layer from the base. They are rounded on top. Okay, so when the bladder is empty, you have like 7 to 12 layers, with the outermost layer being somewhat rounded at the top with nuclei. They call them transitional. It's sort of a misnomer because when they're filled, it scrunches the cells together. So it almost looks squamous. It's just a question of whether you have fluid in the ureters or fluid in the bladder. Okay. Underneath it, you have a rather substantial amount of smooth muscle. Okay. In the ureters, it propels it to the bladder. Gravity alone is not enough. So there's this, again, peristalsis is involved. Segmental movement adjusts the rate of urine. Sympathetic and parasympathetic nerves, they don't play a big role. They're part of it. I guess they play more of a role if they're going to slow it down than speed it up. And because they're retroperitoneal, they're not designed to move, so there's adventitia. And so you might remember, if you remember when we looked at and go back, in digestive, okay, the esophagus looks a whole lot like that, except the lining is a bit different. Kidney stones form in, those are areas, that's why we see them more in the ureter. You can get stones in the bladder a lot. You can get, but when stones form, they tend to form in one of these little, sort of cul-de-sac areas. And what stones induce is smooth muscle spasm. Very famous word for smooth muscle spasm. If you babysat, you heard it a lot. Or if you have little brothers and sisters, colic. Okay. Oh, I have a colicky baby. That's because there were intestinal or gastrointestinal spasms. When it happens here in the ureter, that's why kidney stones are so painful. It's called urethral, URETRAL, colic. So, and there's a lot of things that make them. It can be blood, it can be bacteria, it can be calcium, uric acid. We see it in gout patients. So, excruciating pain, and it's very unpleasant. And it's become a lot more common in women than in men. It used to be almost predominantly men. But we're seeing it more, increasing the numbers in women. I think my guess is has a lot to do with calcium. And one of the problems is you have to take the right kind of calcium. Okay. In the old days, we used to call it Oscal for oyster shell calcium, which is calcium carbonate. That's a little less likely. I'm not as up on the nutrition. My wife tells me that that's not quite as true as it used to be, that there may be a blend that's involved. So we call them calculi, or the name for that. So little ones pass, larger ones, big problems. And again, just like gallstones, lithotripsy rather, sonic waves, smush them, they pass. Lots of different things can lead to it. The bladder, again, nothing more than a storage sac. Temporary storage, retroperitoneal, pelvic floor. Subtle difference is location. In males, the prostate is sort of underneath it, and the ureter passes through, and you'll see shortly, starting next week when we start to do reproductive phys. In females, it's anterior to the vagina and the uterus. So there's a difference, even though the prostate is part of male repro, you're going to see there's certainly a significant difference with regard to them. In both men and women, this is a key area. It's called the trigone. The bladder, just like the stomach, when it's empty or not completely filled, those ridges form. They have the same name as the stomach, rugae. Where rugae don't form and where the urine tends to stay, okay, more than any other area, is this trigone. And it's a triangular area bounded by the entryway of the ureters and the exit pathway of the urethra. And so that's typically where we see bladder infections. So transitional epithelia, the muscle is classically referred to as the detrusor, a name you should remember. Inner and outer longitudinal layers with circular in the middle. It's a little bit different than the gastrointestinal layers, and again, adventitious. And maybe a little bit of peritoneum on the surface area. So, and then you'll see the distinction between, and we'll see this illustration a lot in the male, so I'm not going to go through it, but this is that triangular area, the trigone. Here it is in the female with the shorter urethra, same idea. That's there. The key is, at least from my perspective, as we back up just a tad to finish to complete the unit, is when we're looking at, again, the bladder, the trigone, is the idea is transitional epithelia. And so this is where we see the problem. Transitional epithelia are where, if you're going to get bladder cancer, like I did, it's graded by where it occurs in the epithelia. In other words, is it just in the epithelia? Is it into the underlying, because all epithelial tissue have underlying lucerabular connective tissue, or is it into the muscle? If it is into the muscle, it's a problem. Mine was not. Mine was called TEP1, transitional epithelial type 1. Because of its location, typically it did require some type of additional treatment. In my case, originally, that involved immunotherapy. Just saying. So here the rugae appear, expand and rise superiorly during filling without significant rise in pressure. Typical full bladder, okay, can hold around 500 milliliters and even more if it's overly distended. That's extremely painful. This is a scan. We used to do something similar called an IVP, intravenous pyelogram. Before we had advances in scanning, we would use a dye. Typically, there was a dye that was injected and accumulated in, and it would outline the calyces, it would outline the ureters, and it would outline the ureters and into the bladder. It's called intravenous pyelogram. So when you finally make the exit into the urethra, it transitions, okay? Transitional near the bladder begins to stratify for a pseudostratified kilometer. And as you get near the exit point, longer, obviously in the male than in the female, we go to stratified squamous. You have some sphincters, involuntary at the junction of the bladder and the urethra, voluntary as it gets farther along, etc. And the male, we'll look at this more so in the male. The female, because it's relatively short, has just one set, doesn't have a specific sectional names. In the male, it does because it's a shared system for reproduction. And that's really a better place to look at it. Prostatic, intermediate, and finally the elongated spongy urethra. And that's about it. We're not going to go into the physiology of urination, etc., or the different things that cause problems with it. And that concludes our visit with the urinary tract and the urinary system today. We will begin in earnest. We usually do male first, which is a little easier than female, which isn't that much more difficult. We will certainly get male done and perhaps even most of female done next week before break. And so after break, we'll certainly complete female. And then I'm going to leave the floor open to you to send me some questions about diseases. We're not just talking about urinary tract or reproductive, but infectious diseases in general. We've got a lot of good information to share with you. And none of you who took the 2390 micro, get that. So that's all there is for today.